Welcome to AETCM, the Emergency Medicine channel. So today we are going to discuss a patient with altered sensorium was rolled into the ER, sir. In the first primary 10-second assessment, the patient was drowsy and confused, sir. There were no secretions in the airway and there were no any abnormal breathing sounds. And C-spine appears normal. Second, coming to the breathing, patient is having a respiratory rate of 18 per minute and saturation of 96 on room air, and bilateral air entry was equal. Coming to circulation, patient is having BP of 150 by 70 mmHg and pulse rate of 88 per minute, and all peripheral pulses are palpable, sir. Coming to disability, patient was having GCS of E3, V3, M5 and pupils were 2.5 mm and bilaterally reacting. There is a drop in the GCS and patient was in this drowsy, confused state, sir. Coming to the exposure, patient was having temperature of 98.6 and GRBS was 121 mg per dl, sir. Concluding to the primary survey, patient was having low GCS, but apparently all other parameters are within normal limits. So we proceeded with the adjuncts to the primary survey. We got a VBG and blood gas analysis to be done. Yeah. The patient was having no acid-base disorder, and in the blood gas analysis, we found the electrolyte imbalance of sodium being 114, sir. Okay. So in view of this, initially we proceeded with the secondary survey, starting with the correction of the sodium with 3% saline at 20 ml per hour baseline. We started a sodium correction and going with the secondary survey. So the patient is a known case of recurrent CVA, and he's having old CV in October 2021. Patient is a known case of type 2 diabetes mellitus, hypertension and dyslipidemia. And he had recurrent hospital admissions for dyselectrolytemia, especially hyponatremia, sir. Coming to the events leading to this day, the patient was brought to the ER with complaints of the hiccups since last 4 to 5 days, which were persistent, and the patient had a gradual fall in sensorium. For the last 3 days, he was admitted in the local hospital, and he was getting treated in the view of the hyponatremia, but his sensorium wasn't getting improved, so he was referred to our hospital. Okay. Patient had no any history of loose stools, fever or slurring of speech or chest pain or any trauma history or seizures. No history, sir. Okay. So the lab, on general examination, on head-to-toe examination, there are no any pallor icterus or lymphadenopathy or any pedal edema, and respiratory examination, bilateral air entry was equal, no any added breath sounds, sir. And CVS examination, S1, S2, no added murmurs or anything. CNS examination, patient was in a drowsy state, E3, V3, M5, and by 4 limbs the tone was normal, it was not any increased tone. Okay.
In an emergency room, how do you approach hyponatremia?
First, in hyponatremia, we lab sodium.
First, what you will see?
Osmolality.
First is what? You are seeing a hyponatremia. Your ABG shows sodium 114. First thing is what?
So we have to ask the patient is having low sensorium. We have to keep
that patient's GCS is very, very important. Sometimes you can see lab errors can be there when you are doing sodium in a ABG machine. Lab errors are very, very common because that is not meant for sodium estimation. It's meant for ABG. Along with that, we are getting some values. But sometimes errors can occur. So loss of sensorium or reduced sensorium, GCS is very, very important. So that is the first thing you will see. Then next.
The symptom. I mean, if there's severe hyponatremic symptoms,
that is a sensorium seizures, because basically it affects the brain cells. Yes, so seizure and loss of sensorium or reduced GCS is the most important thing. Second thing,
we need to check for GRBS also. Patient is having loss.
Whether any high blood sugars are there or not. That also can reduce the blood sugar. Sodium. Then
serum osmolality.
That is a lab investigation. Okay. Clinically, what are things you see? Clinical keys are very important.
Airway is patent or not, patient?
Okay, that GCS low, GCS can have difficulty in airway, all this. Next is fluid status. How do you assess the fluid status?
Pedal edema,
So
Krebs.
look for any volume expansion in the body on, like patient is having cardiac failure, liver failure, or kidney failure. There will be lot of fluid accumulation. Edema can be there, ascites can be there. That can produce dilutional hyponatremia. So that is ruled out. Then patient is having any dehydration or not. That is the second thing, because some patients can have severe vomiting, diarrhea. They can lose both sodium and water from the body. So they can have dehydration with hyponatremia. How do you check that dehydration signs?
Tongue. To see it, tongue if it is
Tongue, like routinely you look at the tongue,
triceps.
muscles or skin turgor or urine output, all these things you see. BP you can check whether it is low BP, high BP. Then IVC collapsibility you can check. That all these things should be done simultaneously. So basically you will be doing is checking the patient GCS, blood sugars, fluid status. These three things should be checked in all patients with hyponatremia. Whether it is true or false, we have to check the status like in these three things. Then
In lab.
is immediately lab. Okay. So you have started 3% saline. That you have to tell how you decided 20 ml per hour, that you can tell. That will be good. Otherwise, you start investigating the case. How do you investigate?
Sir, first we have to check whether the osmolarity. First is the osmolarity, hypotonic or eutonic or hypertonic.
When the sodium in the blood is low, normally it has to be hypoosmolar.
Hypoosmolar.
If patient has already received drugs like mannitol, if the blood sugars are very high, then it will be hyperosmolar. Okay, suppose somebody is having altered behavior, some other hospitals might have given mannitol, then they come here, sodium will be unusually low. That is because of the hyperosmolar state. Okay, so that has to be ruled out. So sodium, first thing will be osmolarity of the blood. In real hyponatremia, osmolarity will be low. Second investigation,
would be this urine sodium.
urinary sodium. When there is normally when there is a hyponatremia case, your urine sodium will be
Low.
That is
Kidney
because
will
body
be,
will try to preserve the sodium. But if the sodium levels in the kidneys are high and hyponatremia is there, that means patient is losing sodium through the kidneys. Okay, then third one will be urinary osmolarity. When the sodium levels in the urine is very high, that will increase the osmolarity. So this basically these three investigations should be done. Then next one will be other supportive investigation will be
thyroid function test, glucose, cortisol test.
Okay, basically thyroid function test and one chest X-ray will be enough in almost all patients. But if you have doubt, you have to do other tests also. Like when you rule out, when you want to rule out SIADH, you have to rule out other tests also. Then what do you do? Infection screen is very important, because most of the patient who is having infection, especially urinary tract infection, there will be large amount of urinary loss of sodium can occur. So that has to be done. Infection screen, both urine routine and blood routine has to be done. Then
intracranial pathology is also.
So if suppose if you are correcting the sodium and patient is not improving, then you have to always think about an intracranial pathology and rule out that. Okay, initially normally we don't take CT scan, because most of the time this hyponatremia is the reason for altered behavior. So once you correct that patient does not improve, then you can go for it. Otherwise you should have very good evidence for intracranial pathology, like pupillary asymmetry or sixth nerve palsy or weakness of one side. All these things are there. You can go for imaging. Okay.
Yes, sir, in this case, the initial lab reports were serum sodium being 114, sir.
140.
And serum osmolality was
Serum for sodium 140 is 140.
114. Serum sodium is 114. Serum blood osmolarity is 241, which was low. So hypotonic is there. Then we check the urine sodium. Urine sodium is 134.1.
That is very high. Normally it is
20.
20. More than 40 is mostly SIADH. Okay. Even urinary tract infection also can produce urinary loss of sodium. That you should remember.
Yes, sir.
Cerebral salt wasting syndrome also, you can get more sodium loss from the body. What is the difference between cerebral salt wasting syndrome and SIADH? Cerebral salt wasting syndrome, patient is slightly fluid depleted. There in SAIDs is normal or slightly higher. Okay.
So urine sodium was 134.1, which was high, indicating that there is the salt wasting which is happening, and even urine osmolality was high, which is 441.
Okay.
So the triad of serum osmolality being low, urine sodium being high, and urine osmolality high.
Okay.
So we can consider it to be an case of SIADH.
Okay. So thyroid function test is normal.
Thyroid function test is normal.
X-ray.
X-ray test is normal.
Okay.
No infection.
Have you taken any CT scan?
MRI brain was done because it's an old CVA, again repeated because of low sensorium. To rule out
Any
CVA.
findings are there?
No, sir. Chronic infarct only was there. There's no new change, sir. So, in respect to the diagnosis as being SAIDH, initially we have to restrict the fluid to 800 to 1000 ml per day. Input-output in the ICU setting.
Whenever you are suspecting SAIDH, patient will be clinically normovolemic, but intravascular compartment there will be, or intracellular compartment there will be slightly expansion of the fluid, because that is water retention with sodium loss. Okay, but it will never produce clinical edema. Okay.
So to prevent the excess fluid intake, and then secondary we have to increase the water losses by giving diuretics.
Okay.
And third would be using vasopressin antagonists.
Okay.
Like tolvaptan. We can give tolvaptan like 15 mg OD in the first starting dose.
Okay.
If it is not correcting over 24 hours, we can increase to 30, or we can go to maximum 60 mg per day.
What is the dose received by this?
15 mg per day doses.
What happened to sodium then?
Sir, then gradually it corrected to 119 the next day.
Okay.
And
Did
the
you
next
give sodium infusion?
only the first 24 hours there was 3% saline.
20 ml per hour. Okay.
Corrected.
Normally, when you are giving 20 ml per hour, how do you check the sodium?
Every 6 hourly serum sodium.
When will you stop it?
If there is more than 8 to 10 ml equivalence correction within the 24 hours.
You have to immediately stop it, and you keep somewhere around 128, 130. Rest of the things will be automatically corrected if you are correcting the primary problem.
Yes.
Okay. Tolvaptan is started.
Tolvaptan. And within after 48 hours, the serum sodium became 136.
Okay.
And the patient's sensorium also improved. He started talking and he was oriented.
Okay. So there is no need to increase the dose of tolvaptan. Can you stop suddenly this tolvaptan after?
We shouldn't stop. Okay. We should give for 5 days.
Okay. We can continue it for longer period also. Some patients will have permanent SAIDH. In that type of patients, you can continue. Suddenly, you cannot withdraw any drug, because suddenly this patient may go to hyponatremia. Okay, so that can be continued. Only LFT should be monitored. That is very, very important. Okay, when will you give bolus sodium infusion?
So if patient is having hyponatremic seizures or severe hyponatremia less than 110, in such cases, first 100 ml bolus can be given over 1 hour and reassessed to see the sodium until and unless 4 to 5 milli equivalence of serum sodium is increased, it is fine.
Okay. So if you give very fast sodium in a patient who is having chronic hyponatremia or elderly individual, what would happen?
There can be demyelination of the cerebral pontine area.
What are the types of demyelination syndrome? Types? Pontine and extrapontine demyelination. So previously it was called as central pontine myelinosis. Now it is pontine and extrapontine. Pontine means it will be like a locked in state patient. Patient consciousness will be preserved. Other one, even patient will become unconsciousness, extrapontine. So that we have to be very careful. We should not overcorrect unless until there is a strong reason. Okay, so that should not be done. If the patient is having hyponatremia because of vomiting, diarrhea and all, what will you do? In this,
there will be even hypovolemia also when there is this vomiting and this.
So we can correct. Ideal choice of
0.9% saline, normal saline can be.
Normal saline with oral salt is more than enough. If the patient is having hypervolemic hyponatremia, what would you do?
In that case, is diuretics.
So there you no need to give 3% saline. If you give 3% saline in that condition, what will happen?
There will be more water retention.
So many of these patient hyponatremic case you might have seen, BP is normal or slightly higher. Here also it is
150.
150 by 90. It is slightly higher. So will the BP increase after 3% saline? Suppose the BP
What?
is 150 by 100 and hyponatremia is there. Will he give the 3% saline?
Yes.
You have to give, because there are different conditions like salt responsive hypertension. Some hypertension may respond to salt. If you give more salt, BP will increase. Some hypertension, they may not respond to salt. Here, even the sodium is low, BP is still high. So there is no need to worry about that high BP. You can give still, sodium can be given because sodium levels in the body is low. Okay, that BP does not increase because of 3% saline you are giving for hyponatremia. But patients who is having cardiac failure, liver failure, kidney failure, hyponatremia, if you give 3% saline, that will aggravate the problem. That will produce more fluid retention, more hypertension like that. So there you should not try to do this. You give diuretics. Okay. What happened to the patient afterwards?
After 48 hours, the serum sodium became 135 within the normal range.
Okay.
So we discharged.
So what you understood from this case?
First, we have to check the
So whenever a
clinical signs.
hyponatremia come to the patient, first of all, check whether patient is fully conscious or not. If the patient is fully conscious, no need to like even if it is 110, patient is fully conscious, oriented, talking, no need to start 3% saline. You have time to decide what to do. But if the patient is unconscious or if the patient is having seizure, immediately we have to act. Before that, you have to check some important things. One is fluid status of the patient, like dilutional hyponatremia, fluid will be overloaded. SIADH and all, fluid will be normal U volume, but even then body volume is increased than normal. Patient who is having diarrhea, vomiting, hyponatremia, that can produce hypovolemia. That is very, very important. And once you diagnose the hyponatremia, 3 important tests you have to do. One is serum osmolality, urine sodium, urine osmolality. Okay. Then some important tests like thyroid function test or chest X-ray. All these things are important. Urinary tract infection should be ruled out. Okay. So 3% saline 100 ml contains how much sodium?
51.3
Milliequivalents. Okay. So 1% contains 1 gram. 1 gram contains around 17 milliequivalents. So 3 grams contain around 51 milliequivalents. 1 teaspoon salt you are taking. It contains around 6 grams of sodium chloride. That contains how much?
6 into 18.
So 17 into 6, that may come around 100 something like that. Okay. So what is the advantage of giving oral salt to a patient who is having hyponatremia? And what is the advantage over IV, this one?
Rate of increase would...
Rate of increase, definitely IV is more. But suppose you have 120 sodium, I am giving IV and I am giving oral. What is the major difference? One is you told it is faster. Whenever you require faster correction, you have to give depend on IV. Other one, what is the advantage?
Even the water.
Oral, what is the advantage?
Body will take the required amount.
Only if it is required, only it will take. Suppose it is not required for your body, it will not take. That is the advantage. So how much ever if you want to give oral salt, you can give in a case who is admitted to your ICU. But when you are giving IV infusion, that has to be very careful. If you are giving overcorrection, that can produce very dangerous side effects like pontine myelinolysis. So we have to be very careful when we are giving 3% saline, especially chronic hyponatremia. Acute hyponatremia, faster correction may not be very problematic, but chronic means faster correction creates problem. Okay. Thank you.
Yes.